Hello, good afternoon to one and all. I wish you a very happy International Women's Day. I, Dr. Asabri Sawant, on behalf of Voice of Healthcare, welcome you all to a very special conclave, Better Her Health, a 360-degree focus on women's health, organized by Voice of Healthcare and powered by Zydus. This is the second edition of our International Women's Day celebration at Voice of Healthcare this year. And this year's initiative is to mark the celebration by conducting a day long dedicated event with many eminent speakers from the field of women's health, wellness, leadership, and empowerment, who are all working towards the same goal of bringing women's health and wellness in focus. For this panel discussion, we are empowering her by discussing updates in cancers most affected in the female population. Let me begin this session by asking all our viewers, what is women's health empowerment? Undoubtedly, we understand that empowerment of women through acquiring health information increases their participation in healthcare and consequently their involvement and sense of responsibility in prevention, protection, and promotion of their health, not only just for themselves, but for the family and entire society as a whole. So, without further ado, let me call some very eminent people from this field to take this conversation on Women's Day forward. I welcome Dr. Vani Parmar, who is the
Thank,
professor of surgical oncology at Tata Memorial Advanced Center for Treatment, Research and Education in Cancer. Hello, ma'am.
thank you very
Next,
much.
I welcome Dr. Neeti Raizada, who is Director of Medical Oncology and Hemato-Oncology at Fortis Hospital, Bangalore. Welcome, ma'am. Next, I welcome Dr. Shona Nag, who is Director of Oncology, Senior Consultant Medical Oncologist at Shahadri Hospital in Pune. Hello, ma'am. Welcome. Next, I welcome Dr. Meenu Walia, Director and Head of Department of Medical Oncology at Max Institute of Cancer Center, New Delhi. Welcome, ma'am.
Hi.
Yeah. Next, I welcome Dr. Asta Dayal, who is the lead consultant of gynecology at CK Birla Hospital in Gurugram. Welcome, ma'am.
Hi, thanks.
Dr. Asta Dayal would be leading this session from here on. So over to you, ma'am.
Hi, good afternoon, everyone. And I'm really honored to be moderating this session with all. So, as you know, tomorrow is the International Women's Day, and this year the UN agenda is that gender equality today for a sustainable tomorrow. And so we all have to understand that women are now getting more empowered, and we are talking towards gender equality. But in India, if we see the statistics, the cancer rates among women are still 0.7 million, and third highest in terms of female cancers in after China and USA. So it's a very important topic that we'll be discussing today, and I'm hoping for a very interesting discussion. So my first question, I would like to start with Dr. Meenu Walia. So, ma'am, as could you give us a brief on what are the most prevalent forms of cancers in females in India, and what should really people be aware of?
Hi, Dr. Asta. I hope you can hear me. My voice is clear. So, regarding the common cancers in Indian females, breast definitely has come very rapidly. It has come up. It began with only the metros, and now very commonly we can see breast cancer. At present, the incidence is one in every 28 Indian females. But what is worse is that out of every two Indian females who are diagnosed with breast cancer, one of them will eventually die in a matter of just 1 year. That indirectly highlights that we are seeing more of breast cancer in advanced stages. Apart from that, yes, cervical cancer is also still rules the game in the rural India, very commonly seen in our country among the females. Then, of course, comes lung cancer and ovarian cancer. And also, head and neck cancer is not far behind because of the smoking habits which are prevalent in many Indian women, especially in the rural and now in the urban countries, urban world also.
Thank you, ma'am. So yeah, as you rightly said, 14% of the cancers in India are because of breast, and the rate has now increased. Although it's lower than the West, but it's increasing because of the migration of people to urban areas, and also the change in lifestyle, as you said, smoking and all. So my next question again to you, ma'am, is that. Please tell us about the risk factors associated with different female cancers and how big a role lifestyle factors would play in the same.
So, whenever we talk about risk factors which are associated with cancers, especially among the females, generally we divide them into two groups. There are some risk factors which are non-modifiable risk factors. You cannot do anything about it. And there are certain risk factors which are modifiable risk factors. For example, if you are a female, definitely you are more at risk of breast cancer than compared to your male counterpart. As your age advances, you become more vulnerable to various cancers. Then if there is a family history, if there's a family history of breast cancer, ovarian cancer in the family, you have a higher risk of suffering from these cancers. So these are what we say as non-modifiable risk factors where not much can be done about it. But then, yes, there is an equally rather more important group of what we say modifiable risk factors, and which basically include the lifestyle related risk factors, where a lot can be done. And this is something where we can do to have a good, to have a preventive health care or healthy lifestyle so that we can prevent the risk of these cancers. So, what about the lifestyle related choices? For example, we know that obesity directly is related to as high as 45 to 50% of female cancer. Sedentary lifestyle, physical inactivity is also related to so many cancers. Taking lot of fatty food, taking lot of preserved food, taking lot of processed meats are all related to risk, are all related as risk factors for various cancers, including breast and endometrial cancer. Getting married late, being nulliparous, not breastfeeding, all related to breast cancer. So, not having multiple sexual sexual partners, not having good personal hygiene has directly been found a risk factor for cervical cancer. So these are all lifestyle related factors which are known to be associated with various female cancers in our country.
Sorry, sorry, ma'am. I think I lost my connection there. Yeah, thank you so much. And also, ma'am, I think, I believe you had to leave a little early. So I would like to ask you, Dr. Meenu, what does female health empowerment mean to you? And what would be your one advice related to health empowerment to all the females watching this session?
Female health empowerment to me will mean that females also take a equal responsibility and have an equal role in policy making wherever health related decisions are being made. We hardly see representation of female leaders, of women leaders in various policy making regarding the health acts that we make in our country, or rather even the formulating the guidelines for screening and so much other things. And health empowered lady is the lady who has a health empowered family, who is health aware, and who is aware that these are the implications of not getting the health checkup done in the at the right time. So one my message to all the ladies will be to kindly take charge of their health, come forward and take charge, and just it is good to have a family first attitude, but apart from a family first attitude, we have to take place our own health also first. That is very, very important. So screening guidelines, being aware that there are screening practices available, being aware and being part of this decision making is something which I will say is health empowerment, means health empowerment for the ladies of our country.
Yeah, very true, ma'am. Thank you so much. And I think I'm glad that all the panelists in this panel are also women. So at least we have a small start here. And yes, as you rightly said, to overcome the discrimination, the socioeconomic factors, the gender differentiated access to medical care, we have to empower women and make them policy makers as well. Thank you so much. So, ma'am, moving on, my next question is to Dr. Vani Parmar. What are the guidelines on how often one should get screened for different kinds of female cancers, and what you would generally recommend in your practice?
Right. Thank you very much, Voice of Healthcare, for having thought of this topic here, empowering her. And the question about screening. Let me first start with a controversial answer to that as well. So screening overall, if you look at global screening for cancers, has clearly not shown to be a beneficial one in certain age groups. For example, in breast cancers, the below 50 years age group has not shown any benefit as far as mammography screening is concerned in global data that has come up. But at the same time, we do know that it does benefit to a certain extent when a woman crosses the menopausal age. And there are, of course, various reasons to this as to why does it help certain subsets of women but does not help the others. But overall, before we move on to screening, one has to understand that screening is an act that is done in the overall in the general population. And now, when you're talking about the general population, you need to understand that the risk within the population varies from country to country. We are talking about India here, so I'm going to focus myself to the need for screening in Indian women. Screening per se is when you call healthy individuals over and say that, okay, we are going to examine you via any modality and detect cancers early. So there are two things here. One is you're looking at absolutely healthy women, and second, you're going to give them a diagnosis of cancer if they do have one. Now, when it comes to detection of cancer, the inherent population risk plays a very important role when it comes to how quickly or how soon can you detect, be it cancer, be it hypertension, be it diabetes, any disease condition. So, if you're talking about a population which is overall has a lower risk as compared to the West, and we are actually, if you look at it, we are one-fourth the risk that is seen in the West. So, we are at a lower risk, the women in India. But at the same time, there are a large number of women here because the population is big. The third thing is that 80% of our women are below 50 years of age group. Now, you have to have a modality which is very good in detecting breast cancer in such women. So, when you look at mammography, it does not really have a very sensitive testing capability in below 50 years age group. The reason being that women are still menstruating, the glands are still active, and the breast is very dense. So mammography is not a very excellent tool when it comes to below 50 age group. When you're looking at something that will pick up cancers early. In India, breast cancers are much more common in the age group below 50 years of age group. So commonest median age, as you say, is about 47 to 49 years. So obviously you're looking at something that is to be picked up or identified in women who are still menstruating with dense breast. So there are various other modalities. The other second modality that's been looked at is the breast self-examination. That means being aware of your own breast. Now, breast self-examination on a clinical trial has not shown to be a very efficient tool. The reason being, women are very doubtful about what they feel when they feel their normal breasts. So, since they're not aware of their normal, they are not able to detect something abnormal. And on the other hand, they may actually look at even some small, simple, benign conditions as malignant and they get anxious. So, self breast examination has not really proven itself to be a very good tool when it comes to picking up cancers in screening. The third modality is a clinical breast examination where the breast is examined by some health worker or a doctor or even Anganwadi workers, as it's seen. Now, in such situations, there is evidence now which is generated from India where it shows that clinical breast examination is able to detect cancers early. There is a downstaging. That means those who have been screened by clinical breast examination have detection of tumors much earlier at a much smaller stage. Now, all of this is a lot of scientific jargon when I talk about screening. But understand that whatever screening may do or not do, it does help to detect a cancer a little earlier than before. So, as an awareness tool, screening has really helped in India, because the talk about screening, they talk about being aware of oneself, they talk about being aware of self, is a very important thing, because that has increased awareness. And I think awareness is what has brought cancers to be detected earlier, especially so in breast cancer. When it comes to other cancers, say for example cervical cancer, of course there are guidelines which do specify as to what the modality should be. The age for screening is globally recommended between 25 to 65 years of age, but in India it's 30 to 65. And again, the modality that's being recommended is every 5 years to do HPV detection, as well as pap smears every 5 years. Again, the age to start screening is varying. So in the global thing, it's actually 25, but in India it is recommended to be about 30. Just one second. Sorry. So, as far as the screening for cervical cancer is concerned, the modality again depends upon availability of resources. If you go to peripheral areas, HPV screening may not be very easy, but it is recommended that a pap smear to be done, as papillomavirus staining to be done every 5 years is to be followed. But if not, we have evidence to say that visual inspection of cervix by acetic acid (VIA) is a very effective tool to detect cancers early, and is a very simple thing that can be used by health workers and clinicians to detect cervical cancers as well. Now, of course, it's used for detection of pre-malignant lesions as well as changes within the cervix. Not all of these VIA positive cervixes are actually cancers. So that's how cervical cancer is being looked at. Whereas other cancers, oral cancers, again, this is based on high-risk screening, where populations who have habits which are lifestyle-related habits, they would be screened for oral cancers. So some of these cancers, of course, are all lifestyle-related and therefore are detected as well.
Yeah, thank you, ma'am. As you very rightly said, we do need to sort of make our own guidelines, I feel, because we can't always follow the ACOG and the RCOG, because we have we have a different age group to deal with, and some limitations in terms of the mammographies and the pap smears. So, an extension to the same question, I want to ask Dr. Neeti Raizada, what all screening tests should a female undertake as a first general checkup, and what age do you recommend it for someone who's never been, who's never undergone this screening before? So, should it be like 30 years, 40 years, 50 years? And yeah, so what is your take on that?
Let me start by thanking all of you for having invited me today. See, I'll probably do a quick revision of what we discussed. We have to remember what are the common cancers in our country amongst women. And 26% of women cancers in India are only breast cancer. So most common screening guideline we should be talking about here is breast cancer. Then the second common cancer, that's almost 14% of all women cancer, is cervix cancer. The third is ovarian cancer, but surprisingly, ovarian cancer does not have a screening guideline unless they fall in the high risk category. The fourth is tobacco related. We have many Indian women who chew tobacco. So tobacco related lip and oral cavity cancer. But then of course we have high smokers also amongst women. So that's the fourth most common cancer. And the fifth is colon and rectal cancer. Now, North Indian women and Northeast Indian also have gallbladder cancer, which is a kind of a very intriguing kind of a cancer with very high incidence, but we don't have screening guidelines. So what we have to understand is when we are doing screening, these have to be cancers which are very widely prevalent in the community and the society, and they should be diagnosed at an asymptomatic level. I mean, the person, if they come with symptoms, they are actually having already advanced cancers. So when we are the objective is to detect patients who could be pre-cancerous or pre-invasive. So you could have a breast pre-invasive lesion or a cervix pre-invasive lesion, And when you actually diagnose them, you're preventing cancer, not just doing an early diagnosis, but we are actually preventing it from occurrence. So that's where the usefulness of any of this lie. Screening modality should also be very infrastructure friendly. I mean, we can't have very time consuming, very expensive investigation as screening modality, especially in our country, which banks on so we have to look for very simple techniques which can be used on healthy individuals and give good results. So this is another thing which we have to remember. And of course, what is important is if a woman comes to us, we have to first stratify them as either standard risk screening or high risk screening. So your question is, which age should we start? Any woman, I mean, actually starting at 20 is the time when you start screening. But every woman has a specific risk stratification, whether she falls in standard risk or high risk. And based on her risk factors, we decide what are the screening recommendation and what is the age of screening. So if I have a very strong family history, I have a strong suspicion of a hereditary cancer, I would start 5 years earlier than the youngest member in my family. The screening modality used on me will be very different. I mean, Dr. Vani mentioned extensively about what will we do for a breast or an ovarian cancer, but we would probably do another type of screening methods in a patient who's high risk versus a patient who's standard risk. So when a woman comes in 20, we'll just educate her for a self breast examination, a self skin examination. If she's a tobacco chewer, then we probably tell them for a head and neck oral examination or a neck examination, which can be done herself. From 30 years of age, we would tell them at least do a clinical breast examination every 6 monthly. So visit an oncologist or a trained gynecologist who can do a breast examination. And then from 40, either start an ultrasound examination of the breast or an ultrasound combined with a mammogram, but definitely from 51 to 2 years, mammogram is recommended. From 21 years of age, a pap smear is recommended, especially for a person who's sexually active. And from 30 years of age, pap smear, which is combined with a human papillomavirus test, HPV testing. For a woman who has a strong history of colon or rectal malignancy, starting from 40 to 45 years of age, once a year stool test is recommended to look for occult blood. Now, if again we have strong family history, we would probably recommend a screening sigmoidoscopy or a screening colonoscopy. So that screening colonoscopy can be repeated every 10 years and a screening sigmoidoscopy can be repeated every 5 years. If I'm a smoker, then probably based on my risk, how many years of smoking history I have, and how many cigarettes per day I was smoking, starting from probably 50 to 55, I would like to do a low dose CT scan of the chest done once a year. So everything has to be streamlined based on the age and what are the risk factors. If I'm already hepatitis B or C positive, I would probably recommend a serum alpha fetoprotein along with an ultrasound done 6 monthly. So, and if I have an occupational history of asbestos exposure or certain type of chemicals like vinyl chloride, then the screening would be different. So identify each individual's risk factor, and based on that, basic test should be recommended. All these screening modalities should be generally combined with either a CBC, LFT, and serum creatinine to look for basic organ functions as well.
Thank you so much, Dr. Neeti. That was a very good summary, and it was like a very comprehensive way that you explained the entire list of cancers that we should get screened for. So keeping the medical aspect aside, otherwise for any woman being given a diagnosis of cancer, it's very devastating. And although we know that most cancers are now treatable if detected early, in most of India, it is still considered a big stigma. And so for that, I would like to ask Dr. Shona Nag to share with us the reality and depth of the stigma and myths present around the female cervical and breast cancers and its screening in Indian females, and how can we actually work towards overcoming that?
So thanks everyone for having me here, and it's great to be with my friends and colleagues. So like you said, Dr. Asta, more than a stigma, it's the fear which is associated with the diagnosis. And there's this, even amongst educated women, even in the cities, a woman will have a breast lump and think to herself, it's not paining, not realizing that that's the more dangerous part, and it's going to go away on its own. And they don't really seek help till it's really very late. And there is this attitude with women that they don't want to know, they are fearful, They're scared of coming to the hospital. They're scared of tests. And I don't know whether it's an Indian cultural thing, but women are not confident of their bodies here like they are in the West. We are not taught to be proud, to examine ourselves, to, take care of ourselves. I think Dr. Meenu referred to it earlier that you're too busy with the family or too busy with other things. And we have this behavioral attitude of putting things off. And that's why we land up with a late diagnosis. Also, if I'm diagnosed with breast cancer, what will happen to my family? Will my daughter have a good chance of marriage? I mean, these are the kind of fears that really surround it. And when we talk of pap smears, it's uncomfortable, yes. When we talk of mammogram, yes, it is a little uncomfortable. All these procedures take time. So women don't want that discomfort. I remember going out to a cancer clinical a screening camp, which was in a slum area in Pune itself. And the women didn't come forward for pap smears or even VIAs because they were scared we were going to remove part of their organs. I mean, these are the kind of myths and misconceptions that spread even, before the doctor really gets there. And the fact that the woman may require a biopsy, it's just the invasiveness. There's a lot of misconception that cancer can't be cured and it's like a death sentence. And these kind of things need to really get out of our society. And I think by having programs like this, and kind of opening it up to the public, get as much information as we can, their correct information, is one way to deal with promoting awareness and getting rid of myths, stigmas, and misconceptions.
Very true, ma'am. And as you rightly said, it's more of the fear and the lack of confidence that we have. And it's really alarming that even healthcare workers are at the grassroots level, they are also not very aware about the screening methods. They also don't propagate or help out as much to clear these myths. And actually, women are in rural areas are also disowned when they get a diagnosis of cancer by their own families. So, so as we know that early detection and screening is one aspect of cancer care, but a far wider spectrum of things like the post-surgery treatment in cancers like breast cancer. So what inputs Dr. Shona on the advice for coping with rehabilitation, the post-cancer surgeries, and how can we empower undergoing such treatment?
Yeah, so I think actually Vani is the right person to handle this, but I do happen to see a lot of patients post surgery simply because they are referred for hormonal therapy or chemotherapy. And I think it's very, very important to build their confidence after that. Like just today, I had a lady who came in and she was assured at 70 that she wouldn't need any chemotherapy, but turns out that her cancer was already in stage 3 after the surgery. And naturally, she needs chemo and radiation and the whole thing. So she was rightfully very, very upset. And one had to get her down to explain that this is all to reduce your risk and improve your quality of life, and it's not going to be too drastic, and you need to live a long healthy life. So when women come in after surgery, the first thing is their hand exercises. They have 100 questions. Why is it hurting? Why is it numb? They've been explained everything before the surgery, but we've got to make sure that they keep moving that hand. They take care of that hand. They don't get blood pressure done on it. They don't wear jewelry, rings and bangles. In India, women are very, very, interested in all this. So we keep telling him that hand should not be touched and you have to be very, very careful with it. You have to do your post-surgery exercises so that you don't get swelling in the arm, that your mobility improves, your pain reduces. So these are the rehab skills that we give them. And then before we start the chemotherapy, we naturally talk about their diet, about getting back to normal, getting back to an active life, and then, kind of navigating them through the chemotherapy and then sending them for radiation should they require it.
You also like that?
Sorry, ma'am. Sorry for interrupting, Dr.
Huh.
Asta. As Dr. Neeti is occupied with some other work, could I please ask her the last question? Could you please
Of
ask her the
course.
last question?
So I had two questions for Dr. Neeti. One was, what gaps in cancer care and delivery do you observe that are still present in health systems, and what added support is required from the government side to help facilitate better and more advanced cancer care?
Also, this is a very, I think, unique question, especially to our community, our country. Well, yes, I mean, we know that cancer treatment not just is expensive, it has a lot of socio-economic implications. Coming to the hospital regularly, having, especially we are talking about women cancer here, who actually are the backbone of the house. I mean, having an absence of the main woman in the family probably can be so disruptive, and then spending, I mean, obviously an expenditure which lasts from 6 to 9 months. So there has to be a social structure which can support all of this. Not just you require the patient, we require caregiver to be taking off from work, regular hospital visits. So again, a lot of social implications there, and economics play a very important role. So that's where your second question is, that yes, we need more public private partnership, more availability of such facility, not just in quaternary centers or tier 1 cities, but it should be evenly distributed between tier 2 cities and tier 3 cities, where we have access to basic healthcare. A plan could be in a major center, but there could be delivery in a nearby place where a woman can easily access such places, do the treatment and come back. There has to be adequate financial support, not just from a private vendor, but from a government wherever feasible. We have to have infrastructure in big regional centers in a way which patients are happy to come. I mean, India basically has everything which matches the West in terms of a good center. But however, we need these kind of facilities even in smaller centers so that patient can easily access such facilities and can take adequate care. So there are a lot of gaps which we need to fill. And of course, then the last but not the least is the healthcare providers. We need healthcare providers not just to be concentrated in certain places, but should be equally distributed throughout. There are certain states which don't have good healthcare providers. So giving them the opportunity to be in such places, giving them the resources to be happy and proud to work in such places is also very important.
Thank you, Dr. Neeti. Very rightly said. And then before you leave, I have a final question for you. So what does female health empowerment mean to you? And what would be your one advice related to the health empowerment to all the females watching this session?
So I'll like by saying that, I mean, female and woman empowerment, let's forget about the woman health empowerment. Woman empowerment starts with the right education and the right opportunity. So give a woman a platform to develop her skills, and you have to educate her. When we are talking about health, it is health awareness what we are talking about. And when you are actually empowering a woman, educating a woman, you're not just empowering one person, but the entire family, actually the entire society, by connected relatives, by the connected community. So it's very important to start at the root. Once you empower a woman, you empower an entire system. Not just she herself is benefited, her kids, her family members, her distant relatives, everybody is benefited. So start with education and awareness, and then giving them health access. Again, which I said could be either by private-public partnership, by giving a woman probably a better platform to visit such places. And once they are diagnosed, have a structure which supports the treatment also better.
Thank you so much. Thank you for your insights. And thank you. So now coming back to Dr. Vani, would you like to comment on the rehabilitation for women after cancer surgery?
Yes, definitely. Cancer surgery in my areas, of course, breast cancer, that's what I treat. So cancer surgery, it does not always mean extirpation or a kind of an ambulatory surgery. It also means that the earlier the cancer is detected, the smaller the tumor is, the more aware the woman is, she comes to us at an earlier stage. There is not just a higher chance of cure, there's also a higher chance that the organ can be saved. So there is no need for a mastectomy in such women. And rehabilitation is not just about social rehabilitation. There is also physical rehabilitation. There is mental rehabilitation. There is also the fact that the woman has good coping skills, and that's what we need to actually make use of. And we have seen that in women who have conservations versus mastectomies, that even women who ended up with a mastectomy and to end up by coping well at the end of their treatment. But for all these, you need a very good, strong social support. To able to provide a good social support, you need to educate not just the woman but also the whole family. It's not just the patient who is to be considered here when we're talking about rehabilitation. It's also the surroundings. That means the close family, workplace, and the society in general, for them to accept somebody who has cancer. Cancer is not really a death sentence. It only means there is a disease which needs to be treated. And in fact, if you look at the long term recovery in early cancers, they can be a near 100% cure as well. So you're looking at educating them to be able to cope with their own diseases, educating them so that they're able to come back to their normal. Sometimes it might require a little bit of a mindset change, because there are a lot of women who are stressed out and they feel they can't cope. So you need to help them to walk through their treatment, walk through the disease, and then to come back even stronger. And then we have seen this happening. It's not just that this happens in a few. It just depends upon how well they're able to understand their own disease and they're able to cope with it. So that's one important thing. The second thing is, I've realized that a lot of families don't want to tell the women that they have cancer, and that's actually goes against their rapid recovery and coming back to work and coming back to being their normal self. So uh, actually walking through with them, holding their hand and taking them through the treatment can be not just the healthcare provider's job, it's also the caregiver's job. And together, I think we can make it happen. And rehabilitation is definitely something that we can easily provide to the woman. And as I've said, conservation of breast is something that's a practical thing now. We don't need to remove the breast for cancer. It also is seen in various other cancers, for example, limb cancers. There are, extirpative surgeries have come down, even in oral cancers. Radical extirpative surgeries have come down. So you're looking at cancers that can now be treated by more conservative manner. But then for all of these, we require that the cancer be detected early.
Uh, Thank you, ma'am. And also, my last question to you as well. So, actually, as we all know, that the main challenge to cancer care is how to diagnose all and how to diagnose early on. But having said that, in a country like ours with such a high population, it's quite difficult to tackle the problem of early diagnosis and early screening. So, how do you think we should take on this?
Yeah, as I've already said, screening in India is not going to be a practical solution to
Yes.
finding cancers early, because screening requires a lot of investment. It's not just a matter of just to talk about screening. There is a modality. What do you use to screen? If you're talking about an imaging modality to offer it to everybody, it's going to be a very expensive affair. And we have such a huge population to cover. 50% of our population are women. Now, if you look at the other aspect of it, that for example, clinical breast examination, again, you need to have an army of health workers and clinical for clinical breast examination. Again, not a very practical, doable thing. But what one can definitely make use of is to increase awareness, and that means health education and awareness is the most important tool when it comes to making people aware that cancers can be detected early. And I think media, people like you, Voice of Healthcare, and a lot of others who are interacting with people, we can spread the word around about being aware of oneself. That's the first step. If you know your own normal, you can detect an abnormal much earlier. So health awareness, cancer awareness, knowing your risk factors, understanding what is it that makes you at risk for developing a cancer, modifying your lifestyle, all of these are very important tools when it comes to controlling cancer, detecting them early, and of course, being open to discussion, being able to express yourself and come up with the fact that, look, you have an abnormal finding, not to hide it, but to come forward for an early detection. And that is most important, especially when you become symptomatic. Even if you have got a cancer, let it be detected very early, because the chance of cure is going to be much, much higher. The chance of conserving an organ is going to be much, much higher. So that's the only way that it can work in a population like ours, which has got the being huge numbers. We do contribute to significantly to the cancer population, because our population is so big. Not because we are at a risk population, but more because our numbers are bigger. And I think if we create this awareness and actually create awareness in the population, we will be able to bring down the numbers. We will be able to detect cancers earlier, and we should be able to even offer much better treatment. Of course, healthcare has to be available to all, and that's the goal that we need to really focus on. That let's try and reach out to the people who can't reach out to us, and that's where I think we need to make more improvement and advances.
Yeah, very true, ma'am. Thank you so much. And now, before we end the session, I would like to ask Dr. Shona about her views on what, according to her, is women's health empowerment, and what is the one advice that she would like to give to our listeners.
I think one has to look at two levels. So first, let's talk about women in healthcare. There's a very interesting statistic. When we go for our basic MBBS education, there are 50% are girls and 50% are boys. By the time you get to post-graduation, which is your MD or your MS, 70% are boys and 30% are girls. By the time you get to a super specialty like oncology, like neurology, and so forth, 10% are girls and 90% are boys. So something is wrong, and this ratio really has to change. That's the first step. Second, we need more women in leadership roles and health leadership roles to take things ahead. And thirdly, speaking as a woman herself, I have also been guilty of ignoring my health. I don't think it's right. I think unless a woman puts herself first and takes care of her physical health and her mental health, which today we know is so, so important, she's no good to anybody else. She's no good to the family, and she's no good if she's a doctor to the patients she treats. So take that time off, get your peace, get your mental calmness, get your physical fitness up, look after your diet, look after your activities, do what you love, and put yourself first. So that's most important.
Thank you so much, ma'am. Yeah, putting yourself first, I think that's the best message you can give everyone. And Dr. Vani, what are your views on women empowerment, and what message would you like to give everyone?
I think most has been already said, and the most important, as I see, is to make a woman aware that she has the power to decide things for herself. She does not need somebody else to take that decision, and it means that she has to put herself first and the family second. Very easily said, most difficult to do, but it's exactly what we need to educate women about. I think self health and self care comes much before the care for everyone else. Does not mean that you're being selfish. It's because you're making yourself stronger to be able to look after your whole family. If you don't,
Correct.
if you ignore yourself, you're never going to be able to take care of them. So I think to be able to good to your family, you have to first be good to yourself. Take care of yourself, be aware of yourself, be aware of your needs, see to it that your needs are met. And that's the most important thing. Never put yourself down as being the last in the family. Don't be the one to say, I'm going to eat last because I'm going to feed the family first. No, if you don't, if you're not strong enough, your family is going to weaken and it's going to fall apart. And I think that's the message I have for every woman.
Thank you so much, ma'am. Very true. If a happy and healthy woman would mean a happy and healthy family, a community, and the entire nation. So I think we really need to understand. It was great having all of you for this very enlightening session. Does more of such sessions for women empowerment. And thanks everyone for joining in and from your precious time, taking our time. Thank you so much.
Thank you, Dr. Astha, for so expertly leading this session. But ma'am, before you leave, I have one more question for you. The same one. Sorry, I guess your network is not very strong right now. But I had the same question for Dr. Astha as well, that what women empowerment is to her. Yes, she is back again.
Sorry, I was doing it from my phone, so every time I have a call, I get disconnected.
Sorry, ma'am. Just quickly, I have this same question for you as well. Thank you, first of all, for so expertly leading this session for us. Also, I would want your views on what health empowerment for women is for you, and what would be your one message to all the females that are watching this session with us.
So I think everybody has already said everything that I wanted to say as well. So I think we should take charge. We should not blame others for being less empowered, and we need to take charge of our own health, our own being, and we have to put ourselves first, as ma'am said. Yeah, thank you.
Thank you so much. That was so great, ma'am. I would also like to put in my 2 cents on behalf of Voice of Healthcare, that we believe, and I believe, with a female dominant organization, that voicing your opinions when it comes to what your needs are in healthcare, in education, in leadership, is health empowerment and female empowerment for me and for us over here. So I would like to thank you all our expert panelists, for taking out time to share their expertise with us, and all the work that you all are doing, empowering women in your everyday practice and inspiring future healthcare leaders. And we hope together we are able to make a good difference. Thank you so much for taking your time. We greatly appreciate you. And also, I would like to thank all our viewers for staying with us till the very end. I would just wish a happy International Women's Day to all of you again. And stay tuned for more. Thank you so much.
Thank you.